Hi there, my highly treasured, esteemed, and honored viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare sector workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal treatment or clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services in your line of duty. So I would like to humbly urge you to sit back and spare me part of your very precious time to share some tips with you. Welcome. So our first question reads, Mrs. PMM, a 39-year-old female patient, takes 5 milligrams of warfarin once daily for the treatment of unprovoked venous thromboembolism, what we abbreviate as VTE. A home pregnancy test she did revealed an unplanned pregnancy, despite her complete adherence with her oral contraceptives. So my question to you is, which of the recommendations below would best suit Madam PMM now? Would you recommend she changes warfarin to enoxaparin? Would you increase her warfarin dose by 50%? Would you change her warfarin to apixaban? Or would you decrease her warfarin dose by 50%? I'll give you 10 seconds to choose the correct answer. So A is the correct answer. I would opt to change her warfarin to enoxaparin. Now, unfractionated heparin and low molecular weight heparin are the preferred anticoagulants in pregnancy. Like in this case, due to the potential risk of other agents to cross the placenta that could cause harm to the fetus. Now, reducing the warfarin dose doesn't reduce the potential fetal risk that is posed, and unfractionated heparin and low molecular weight heparins do not cross the placenta and are therefore preferred in pregnancy. Now, warfarin crosses the placenta and may lead to fetal bleeding and even CNS abnormalities in extreme cases. And that makes me settle for answer A as the correct answer. Let's move to the next slide, please. Madam TOO, a 57-year-old female patient, presents to your hematology clinic for a scheduled appointment. She has a past medical history of non-valvular atrial fibrillation, hypertension, and hyperlipidemia. Currently, she takes 5 milligrams of warfarin once daily, alongside 20 milligrams of lisinopril once a day, 12.5 milligrams of carvedilol twice daily, and high-intensity statin, rosuvastatin, at a dose of 40 milligrams at night. TOO reports that she was diagnosed with a urinary tract infection 4 days ago and discharged on cotrimoxazole double strength at a dose of 1 tablet twice daily for a duration of 3 days. Today, her lab values are within normal limits except for her INR, which is pretty high at a value of 5.2. And from the details and the clinical notes, you see that for the last 90 days, her INR has been within the therapeutic range. So my question to you is, which of the therapeutic plans listed below would best suit TOO's case? Would you opt to hold warfarin for 2 days and then decrease the dose to 4 milligrams once daily? Or would you maintain status quo? Or would you hold warfarin for 2 days and then continue the current warfarin regimen? Or would you hold warfarin for a day and decrease the current warfarin regimen to 5 milligrams daily except 7.5 on Saturday? I'll give you 10 seconds to choose the correct answer. D is the correct answer. Holding warfarin for 2 days will help quickly lower TOO's INR and decrease her risks of bleeding or hemorrhaging. It would be appropriate to continue her current warfarin dose because her INR, from what we are told earlier, has been therapeutic at this dose for the past 3 months. Her INR was likely elevated at this visit due to a drug-drug interaction between warfarin and cotrimoxazole. Now, typically there is no need to adjust warfarin therapy only in cases where the INR is within 0.1 to 0.2 of the goal. So that makes answer B wrong. And I have a strong feeling there is no need to decrease her warfarin regimen to 4 milligrams once daily since her INR has been stable and within range for the past 3 months. Now, increasing the weekly warfarin regimen will significantly increase her risks of bleeding. Remember, her INR is already above the 2 to 3 goal. And a dosage increase would further increase her elevated INR, which is at 5.2, way beyond that mark. So I would not opt to increase it. I would just like to add that warfarin therapy is well managed when the patient's time in therapeutic range, what we abbreviate as TTR, is above 65%. Now, if this level TTR isn't achieved, consider strategies to improve it. For example, frequent monitoring, consistent vitamin K intake in diet, dose monitoring of drug-drug interactions, or switching to a DOAC, for example. Now, warfarin, as we know, has numerous drug-drug interactions, for example, with fluconazole and other azoles, with amiodarone, with cotrimoxazole, and even with metronidazole. So when it's co-prescribed with those agents, we need to watch out and, if possible, make those adjustments. Let's move to the next slide, please. The question reads, Mrs. JKG, a 42-year-old obese female patient, presents to the clinic with chief complaints of unilateral leg pain and swelling. She is diagnosed with unprovoked DVT and she meets the criteria for outpatient management of a DVT. During this particular visit, her serum creatinine and her liver function tests are reported to be within normal limits. Now, the medical resident on duty seeks your recommendation or opinion for medical management of this case. So my question to you is, which of the recommendations listed below would be the best for initiating Madam JGK's DVT treatment today? Would you advise the resident to prescribe adoxaban alone, or rivaroxaban alone, or a low molecular weight heparin alongside rivaroxaban, or warfarin alone? I'll give you 10 seconds to choose the correct answer. Personally, I would settle for rivaroxaban alone. Now, rivaroxaban has been shown to be non-inferior to warfarin or enoxaparin for rates of recurrent VTE. Warfarin should not be initiated alone. When you opt for it, it should be co-administered with low molecular weight heparins for at least 5 days, what we call bridging. Now, in randomized controlled trials, low molecular weight heparin was administered for 5 days prior to edoxaban therapy. Therefore, it is recommended that parenteral anticoagulation be given for 5 days, followed by initiation of edoxaban. And because of that reason, alternative A is wrong. And I would like to add that there is no evidence to support concomitant use of low molecular weight heparins and rivaroxaban. Rivaroxaban doesn't require any bridging at all. Now, rivaroxaban and apixaban are comparable to warfarin for VTE treatment and are possible first-line options when appropriate. Warfarin may be used as first-line and requires at least 5 days of concomitant dosing, what I call bridging, with low molecular weight heparins. Just underlining that. I would like to also add that edoxaban and oral dabigatran were non-inferior to warfarin for VTE treatment. However, studies included at least 5 days of pre-dosing with low molecular weight heparins. Therefore, low molecular weight heparins should be administered for 5 days prior to the initiation of edoxaban or dabigatran if you opt to use them in the treatment of VTE. Let's move to the next question, please, which reads, your hospital gastroenterologist in the surgical consultant clinics in your hospital consults you regarding a 78-year-old Caucasian male patient with non-valvular atrial fibrillation. Now, this patient has a CHADS-2 score, CHADS-2 VAS score of 3 on apixaban, and is having a bowel resection, which is a pretty high risk procedure. Hemorrhage could occur. His renal and liver function tests are normal during this particular visit. So my question to you is, which of the recommendations below regarding pre-procedural apixaban management would be the best for this patient's case? Would you choose to hold apixaban 1 day prior to the procedure and restart the next day after the procedure? Or is it true that apixaban doesn't need to be held for a CHADS-2 VAS score of 3? Or is it true that we should hold apixaban for 2 days prior to the procedure and restart 3 days after the procedure? Or should we hold apixaban for 2 days prior to the procedure and restart 2 days after the procedure, bridging with enoxaparin? I'll give you 10 seconds to choose the correct answer. Personally, I would hold apixaban for 2 days prior to the procedure and reinitiate it 3 days after the procedure. Now, based on what we call the PULSE trial, PULSE, for a high bleed risk procedure like bowel resection, which we are referring to in this case, it would be appropriate to hold apixaban for 2 days prior to the procedure and to restart apixaban 2 to 3 days after the procedure, so long as the patients have normal renal function. Now, the decision to interrupt apixaban for a procedure is primarily based on the classification of the procedure as high or low risk bleeding, and not on the CHADS-2 VAS score at all. Now, in my opinion, holding apixaban for 1 day prior to the procedure when the renal function is normal, is a strategy used for low-risk procedures such as dermatological procedures, for example, or dental procedures such as root canal or multiple teeth extraction. And there is no need to bridge with enoxaparin for DOAC, the direct oral anticoagulants, due to their short half-lives. Now, warfarin is typically held for 5 days prior to a moderate to high bleed risk procedure. If you opt to use warfarin, you would need to hold it for 5 days. Now, for patients who are at a risk of thrombosis, bridging with enoxaparin is appropriate to reduce the duration with without anticoagulation if you opt to withhold warfarin. Now, the dabigatran is heavily cleared via kidneys, and therefore in patients with renal dysfunction defined as a creatinine clearance below the 50 ml per minute mark, the hold time prior to the procedure are slightly longer. Now, 2 days can apply to low-risk procedures, and then 4 days can apply to the high-risk procedures. That's just by the way. Let's move to the next slide, please. So the question reads, which of the statements below best describes the rationale for declining platelet count that leads to thrombocytopenia in patients experiencing heat? Is it reduction in the production of thrombopoietin, or is it utilization of platelets in the formation of clots or thrombosis, or is it the platelets undergoing antibody-mediated hemolysis, or is it D, suppression of the bone marrow production of megacardiocytes? I'll give you 10 seconds to choose the correct answer. So B is the correct answer, utilization of platelets in the formation of clots or thrombosis. The larger unfractionated molecules of heparin are able to bind to other biologic substances that create an antigenic response by the body, and that leads to the formation of antibodies. Now, in patients experiencing heat, the platelets are being activated and they are forming thrombi that ultimately lead to reductions in the platelet count. And that's the explanation and the rationale behind choosing alternative B. Let's move to the next slide, please. The question reads, which of the treatments listed below would most likely have long-term benefits in the management of a 38-year-old black male patient with a known history of sickle cell anemia and 3 episodes of acute chest syndrome in the past 1 year? Is it penicillin, hydroxyurea, erythropoietin, or ticagrelor? I'll give you 10 seconds to choose the correct answer. Hydroxyurea it is. Patients suffering from sickle cell disease are at an increased risk for chest syndrome, which is a common form of pulmonary disease in this kind of patients. Now, acute chest syndrome confers a great risk of morbidity and even mortality in extreme cases in this patient population. Such patients usually present with a temperature greater than 1 or 1.3 degrees Fahrenheit. They may cough, they may wheeze, they can experience increased labored breathing, they can be tachypnic, and they even tend to have low oxygen saturations. Now, patients are known to benefit from the long-term hydroxyurea therapy because it's known to reduce the number of acute pain episodes by as much as 50% and episodes of acute chest syndrome by up to 40%. Therefore, daily hydroxyurea therapy is indicated when patients with sickle cell disease have had 3 or more episodes of acute pain requiring opioid therapy. I would just like to add that hydroxyurea therapy in sickle cell disease works by increasing the concentration of hemoglobin F specifically, which are less likely to sickle and cause occlusions in the blood vessels. Now, hydroxyurea also works by increasing the water content and the deformability of the sickled red blood cells, and it alters the adhesion of these red blood cells to the endothelial lining in the blood vessels. Now, all of this favor a reduction in sickling of red blood cells and occlusion of the blood vessels to blood flow. Now, prophylactic penicillin use can be beneficial as it reduces acute chest syndromes caused or exacerbated by bacterial infections in children up to the age of 5 years, but not in adults. So we use the penicillins only in the pediatric population up to the age of 5. Erythropoietin would be possibly helpful if the patient had low levels of erythropoietin from chronic renal failure. And then ticagrelor, which is alternative D, is a reversible antagonist of the P2Y12 ADP receptors on the platelets, and it's only indicated in patients with the acute coronary syndrome and not acute chest syndrome in SCD, sickle cell disease. So that was just meant to trick you and to trap you. Let's move to the next slide, please. QPN, a 43-year-old male patient with chronic kidney disease on dialysis due to his uncontrolled hypertension, is receiving epoetin alpha for his anemia. His iron levels are reported as normal. So my question to you is, at what HB levels should the epoetin alpha be stopped and or reduced in dose due to a concern of an increased mortality risk? Is it once it reaches 9, 11, 7 or 13 milligrams per deciliter? I'll give you 10 seconds to choose the correct answer. So 11 it is. There is a black box warning for erythropoiesis stimulating agents regarding an increased risk of cardiovascular events, myocardial infarction, stroke, venous thromboembolism, and even mortality when they are used to a target of greater than 11 milligrams per deciliter. Therefore, such a dose should be reduced or medication should be stopped if the patient's HB has attained the 11 milligram per deciliter value. Now, prior to the initiation of an ESA, iron stores should be assessed and any presence of iron deficiency should be corrected first. That would be the right way to manage these patients with chronic kidney disease who are anemic. Let's move to the next slide, please. The question reads, Mrs. JMT, a 57-year-old female, recently underwent knee replacement surgery. She has a past medical history of chronic back pain, hypertension, and hyperlipidemia. She is pretty obese with a BMI of 36 kilograms per meter squared. She has normal liver and renal functions according to the labs. So my question to you is, which treatment strategy listed below would be the most appropriate for venous thromboembolism prevention in this patient's case? Would you opt for 40 milligrams of enoxaparin administered subcutaneously once a day? Would you opt to administer apixaban 2.5 milligrams orally twice daily? Or would you settle for 150 milligrams of dabigatran twice a day orally? Or would you administer 60 milligrams of edoxaban once daily. I'll give you 10 seconds to choose the correct answer. Opt to administer 2.5 milligrams of apixaban twice daily orally. Now, apixaban has shown a superior reduction in VTE events compared to enoxaparin 40 milligrams daily in hip and knee replacement surgery, with no significant increase in major bleeding at all. Apixaban is also preferred by many patients because of the route of administration, which is oral. Not everybody is willing to inject themselves. Dabigatran is available in the United States for VTE prevention in hip replacement surgery, but not for knee replacement surgery. Then enoxaparin should be dosed at 30 milligrams subcutaneously twice daily for VTE prophylaxis. Now, enoxaparin 40 milligrams subcutaneously once daily is appropriate for hip replacement surgery. Remember, she underwent knee replacement surgery, so that would be the wrong choice. I would also like to add that edoxaban isn't approved for use in knee replacement surgery in the US by the FDA. And just as a by the way, apixaban and rivaroxaban are approved for VTE prophylaxis in knee replacement surgery. Apixaban, dabigatran, and rivaroxaban are approved for VTE prophylaxis in hip replacement surgery. And the unfractionated heparin has shown insufficient protection against VTE in patients undergoing orthopedic surgery and should not be used. That makes A wrong. Now, the duration for VTE prophylaxis in knee replacement surgery is at least 10 days, according to literature inserts. And the duration for VTE prophylaxis in the hip replacement surgery cases is longer, 4 to 6 weeks. So those are just either way. Let's move to the next question, please, which reads, what is the most frequent side effect of pegfilgrastim, which is marketed as Neulasta, or filgrastim, which is marketed as Neupogen? Is it transaminitis, hyperuricemia, bone pain, or splenic rupture? I'll give you 10 seconds to choose the correct alternative. So bone pain it is. Now, pegfilgrastim and filgrastim are colony stimulating factors which act on the bone marrow. They are used to prevent chemotherapy-induced neutropenia. Their most common side effect is bone pain, which occurs in over 30% of cases who receive this agent. Now, typically, the pain presents during the nadir period after chemotherapy. Just as a by the way. Let's move to the next question, please. It reads, JWW, a 64-year-old male, presents to your clinic. This patient has a past medical history of atrial fibrillation, uncontrolled hypertension, GI bleed, type 2 diabetes mellitus, and he takes metformin, carvedilol, atorvastatin, omeprazole, and lisinopril. During this particular clinic visit, the serum creatinine is 0.9 and the creatinine clearance is 40 ml per minute. So my question to you is, which recommendation below would best suit JWW's management? Would it be rivaroxaban 20 milligrams once daily with food, or apixaban 2.5 milligrams twice daily orally, or aspirin at a dose of 325 milligrams once daily, or would you opt for 75 milligrams of dabigatran twice daily? I'll give you 10 seconds to choose the correct answer. So apixaban 2.5 milligrams orally twice daily it is. Apixaban has been shown to have lower major and intracranial bleeding risks compared to warfarin, for example. And in this particular case, it's dosed appropriately for Mr. JWW's renal function. Now, aspirin at a dose of 325 milligrams orally daily isn't recommended for anticoagulation in a moderate to high risk patient for purposes of stroke prevention. Rivaroxaban, on the other hand, is recommended to be used at 15 milligrams once daily in patients with AFib and a creatinine clearance of between 15 and 50 ml per minute, requiring anticoagulation. Now, the bigatron is dosed at 150 milligrams orally twice daily for patients with creatinine clearance above 30 ml per minute, unless interacting medications such as, for example, amiodarone are being used by the same patients. Now, I would just like to add that renal function should be evaluated at least annually, and creatinine clearance should be calculated based on the Cockcroft-Gault method. Bleed risk with the DOACs is mostly similar when each agent was compared to warfarin in studies that were carried out. Apixaban, for example, was shown to have a lower occurrence of major bleeds and intracranial bleeds. It may be a better option in a patient with a high bleed risk or a history of bleeding incident. Now, apixaban, just for your information, is a substrate of the CYP3A4 and the P-glycoprotein, and is thus at a risk of being associated with many drug-drug interactions. So if you choose to co-administer it with several other drugs, you have to watch out for any interactions that would negatively impact on clinical outcomes. Let's move to the next question, please. It reads, which of the statements below is true concerning cyanocobalamin? Is it true that it requires appropriate levels of iron to be present in the body to function? Or is it true that it requires the presence of intrinsic factor for absorption if administered orally? Or is it true that it is used for the treatment of microcytic anemia? Or is it true that it is also known as vitamin B9? I'll give you 10 seconds to choose the correct answer. So it requires the presence of intrinsic factor for absorption if it is administered orally. Now, vitamin B12, which is cyanocobalamin, is used for the treatment of vitamin B deficiency. It can also be used in the management of pernicious anemia, vitamin D deficiency from gastrectomy, for example, or from ileoresection, inflammatory bowel disease, sprue, and or even gastric bypass surgery. Now, vitamin B12 and pernicious anemia are associated with macrocytic anemia, not microcytic like in the alternative C. So that makes answer C wrong. Now, microcytic anemia is seen in iron deficiency anemia, not in vitamin B12 deficiency cases. I would just like to add that cyanocobalamin can be administered orally or IM, and if it's administered orally, it will require the presence of intrinsic factor secreted from the stomach to be specific in order to be absorbed in the terminal ileum of the GI tract. Now, just like to add that alternative B, vitamin B9 is also known as folate or folic acid. It is also used in the treatment of macrocytic anemia from folic acid deficiency. Now, iron isn't needed for vitamin B12 to function appropriately. Iron is needed in order for erythropoiesis, that is erythropoiesis stimulating agents to work effectively. Then, just as an emphasis, cyanocobalamin is used for the treatment of macrocytic anemia that occurs when there is a deficiency of vitamin B12. Now, macrocytic anemia is identified on labs by a low hemoglobin and hematocrit, but a simultaneous elevated mean corpuscular volume, which we abbreviated as MCV, a mean corpuscular hemoglobin, which we abbreviate as MCH, and a mean corpuscular hemoglobin concentration, which we abbreviate as MCHC. Those are just as by the way. Let's move to the next slide, please. DSS, a 50-year-old male patient, presents to anticoagulation clinic for warfarin follow-up. He has a past medical history of unprovoked DVT in the right lower extremity, which occurred 72 months ago. He also suffers from gout and back pain. He takes 2 to 3 beers weekly and smokes 1 pack of cigarettes on a daily basis. By profession, he's a truck driver and it typically drives long stretches with limited breaks. Currently, he's on warfarin 7.5 milligrams once daily. His INR is 2.8 in the clinic. He has a creatinine clearance of 55 ml per minute and his BMI is 24. His liver function test is within normal limits, and he complains of the difficulty to come to the clinic for frequent lab monitoring with the warfarin therapy, and he asks you about switching to apixaban therapy. So my question to you is, which therapeutic plan below would suit Mr. DSS the most? Would you opt to discontinue his warfarin and initiate apixaban at a dose of 5 milligrams orally twice a day? Or would you opt to discontinue his warfarin and initiate apixaban at a dose of 2.5 milligrams orally twice a day? Or would you choose to continue warfarin therapy due to contraindication with apixaban? Or would you opt to continue warfarin and initiate apixaban at a dose of 10 milligrams orally twice daily for 7 days before halving that dose? I'll give you 10 seconds to choose the correct answer. I would discontinue warfarin and initiate apixaban at a dose of 2.5 milligrams orally twice daily. Now, just like to emphasize that DSS would benefit from prophylaxis doses of apixaban for DVT. Now, the Amplify-XT trial, AMPLIFY-EXT trial, showed that in patients who have completed 6 to 12 months of anticoagulation, long-term apixaban treatment reduces recurrent VTE or all-cause mortality without increasing rates of major bleeding. Very promising results indeed. So long-term anticoagulation is beneficial for this particular patient DSS, since he still works as a truck driver and has a low risk of bleeding, in my opinion. Remember, DSS doesn't have a contraindication to apixaban therapy. It is important to individualize patient therapy based on a patient's preference and needs. It would make adherence or compliance or concordance easier. Now, contraindications to apixaban may include previous allergy to the same, moderate to severe mitral valve stenosis, and even mechanical heart valve replacement. Now, he doesn't have any of those. Now, remember, we are told this patient has completed 6 months of anticoagulation therapy at an appropriate treatment dose for VTE and for DVT, and extended therapy can be started at a lower dose. Now, option D, in my opinion, is an appropriate regimen for a newly diagnosed acute DVT. Now, DSS's case occurred 3 years ago, so it doesn't apply to him. Now, just like to add that patients with proximal DVT should receive at least 3 months of anticoagulation therapy, and an extended course of anticoagulation should be determined based on a combination of venous ultrasound findings, risk and benefit balance, patient compliance with therapy, and even their preference. The patient has a say. You have to get their buy-in if clinical outcomes are to be optimal. Now, for extended secondary prophylaxis against DVT, patients can be treated with low-dose aspirin, not the 325. Now, apixaban can also work at a dose of 2.5 milligrams twice daily, and even rivaroxaban at a dose of 10 milligrams orally once daily. In general, anticoagulation therapy is preferred over aspirin therapy, which is antiplatelet therapy in such cases. Let's move to the next question, please. So, my highly esteemed viewers and listeners, that brings us to the end of part 41 of our pharmacotherapy MCQ series focusing on hematology. If this video helped you in any way, I would like to humbly urge you to give it a thumbs up and to like it and to share it widely with your peers. I'm very grateful that you continually support me and collaborate with me. I would like to promise you that the best is yet to come, and I look forward to interacting with you in part 42 of our pharmacotherapy MCQ series. Thank you for always being there for me.